used to hit him on the head right in that exact spot. And, you know, he had a very difficult relationship with his father of longstanding, and he attributed the growth of this to that idea. So that was a little off, you know, when we were speaking with him. So we created a plan, and we admitted him to the hospital, and we worked him up. You know, we did the usual things, the imaging that you would do, MRI, and consultations with, you know, wide variety of services that we have. We had our dermatologists involved. We had the oculoplastic surgeons involved. We had the neurosurgeons involved. We had the radiation oncologists involved. The medical oncologists were contacted. You know, we created a plan. It took several days. These were all in hospital consultations. So, you know, we weren't having them traipse from office to office and that kind of thing. And we decided that we would go and resect this, and went through a really complete discussion. Our residents were really great at this. The chief resident, well, suffice it to say, he was the valedictorian at USC and undergraduate. He's a very bright individual and really patient, and talked to him about loss of function of the eye and the possibility that, you know, we would need to resect dura and all this other stuff. And we also talked about free flap reconstruction. At San Francisco General, actually, our plastic surgery colleagues do the micro work for us at that particular hospital. And so they also went over the ins and outs of microvascular free flap reconstruction, which we thought would be required. So he consented to the surgery, and you know, we believed at the time that he had adequate capacity to do that. As I said, there was no family to call, no other person to talk to. We had no children, and we you know, compartmentalized, I don't know, 16 hours in the operating room on our block time. You know, this is a resource-constrained environment. Large volumes of patients taken out a day in the OR, or more than a day, is a big deal. Got the ICU all lined up. And at 11 o'clock at night, you know, he was NPO and all that. He got up and just walked out of the hospital. Just, you know, came in the morning, go, what's going on with the case? They go, oh, Mr. M left. He just left. Go, oh, all right. He left. So, didn't hear back from him. You know, we called the numbers of his apartment, no answer. And then about 2 weeks later, Mr. M came into the emergency room, and it was like nothing had ever happened. You know, this was in the days of paper records, by the way, at CSFG. We were late to get the EMR. So he walks into the ER, and you can imagine what happens in the ER, right? The ER doctors freak out. It's like, oh my God, what's this? This is an emergency. And so the team goes down and does an evaluation of him and says, you know, Mr. M, why did you leave? You know, because we were all set to do this. We had the OR and all that. And, you know, we went over this with you. And he said, well, I got scared. And I was afraid about, you know, I was afraid about the surgery not being successful. And I was afraid about losing my eye. And I didn't want to, I just got scared and left. And so at this point, we got a psychiatry consult. And I got to tell you, this happened a few times, no hard feelings, but the psychiatrists don't like consulting on this type of thing. They didn't like it in New York, and they don't like it in San Francisco. They just don't like approaching the idea of a patient deciding not to pursue surgery very specifically. They just don't like to be involved in the middle of this. So they came down and they talked to him. And as I said, he was a very nice person to speak to, you know, very polite, respectful. And they came back after a relatively short time, and they said, you know, he has capacity, and we believe he would also be determined to have competence to make his own decisions. And we go, okay, you know, to us, it seems like there's an underlying sort of delusional fear, a little bit of perseveration. He's not really processing this information well. And there's also another aspect of this type of disease in that this is not quick. So, if you're talking about, if you decide to not treat this is not going to like happen quickly where he's going to, have a demise. This is going to go on and on and on very, very slowly and start removing more and more function and create emergencies and other problems. And I don't think that anyone other than surgical teams or people dealing with cancer really have the perspective about the kind of problems that can occur for someone like this. We're talking bleeding, we're talking erosion into the brain, all kinds of stuff. So anyway, the psychiatrist didn't 5150 him, and so we admitted him again to the hospital at this point, and we redid all the consultations, and we took up, we scheduled time in the operating room, another 16 hours of OR time, and set him up to have this done. Painstakingly discussed the surgery with him again, and he was all on board, and all the teams were lined up. And I think what happened is night before surgery, NPO at midnight, the team goes around at about 8 o'clock at night, just stops by. Hey, Mr. M, how you doing? Everything okay? Any questions for me? No problem. I'm all set. Let's go. About 11:30 at night, gets up, walks out of the hospital. Okay. So that was admission number 2. Now we go to admission number 3, and this is where I became really more involved. I was the chief of service at San Francisco General Hospital for 20 years, and he came into clinic, and I personally, at this point, called the psychiatry consult when he came back and talked to Mr. M, how are you doing? Usual stuff. And the psychiatrist comes in and says, listen, he's in charge of making his own decisions, and that's our opinion. And I said, okay. And I talked to our head nurse, and I called the San Francisco City Attorney's Office, and I said, I have this patient that I really want you to evaluate because I think that he has capacity, but I don't think that he has competence to make this decision. He's not really making a rational decision about what's going on, especially since he keeps coming back into the care environment. So it's kind of a double bind. So anyway, I made that phone call. So informed consent has a prudent patient standard. The idea is that you provide the patient adequate information to present information about a condition, to recommend treatments and discuss alternatives, and to provide the patient information about recovery. It has to be free of coercion. And basically, the capacity issue has to do with discussing options and consequences and being able to hear and understand and not being under the influence of medications or drugs, and to not have psychopathology such as delusions. But the patient also must have a competence to consent or refuse. And capacity is normally something it's not usually something that you have to think about. It's usually implied in the beginning of the visit. But competence is actually a legal concept. It's only determined formally in legal proceedings. And physicians make a capacity assessment during encounters before accepting a patient's decision. And usually the decisions have to be accepted as valid. It's implicit, but it is a physician's duty to raise questions of incompetence if there are substantial deficits in decision-making that are present. So what are the types of deficits? Well, one is communicating choices. So if you have somebody who can't communicate, that's a deficit, and it would be like somebody who comes in unconscious without family members, and they can't communicate. There's also a defect in understanding relevant information. But it's really number 3. It's the appreciation of the situation and competence and consequences, rather, that I think were at play here. Faden and Beauchamp, in a paper that they wrote, said, quote, "One can understand what one is told without understanding the specific implications that it carries for one's future. And there can also be a pathologic distortion or denial, or a cognitive or affective impairment. And you can also have delusions about the condition, the outcomes, or the motivations of others." And I think that there were delusions about the condition and outcome present in this particular situation. And then finally, there's the idea of manipulating information rationally. And I think that there was a portion of the decision-making here. Now, that can be due to psychosis, delirium, dementia, extreme phobia, which might have been at play here. Anxiety also might have been at play. Euphoria. We didn't really detect specific depression. And there can be anger, not in this case, but that's also something that can occur. And so the standard is making recognizable decisions. So assessing a patient's psycholegal abilities is really inherent in every medical interaction that you have. But the idea of having a formal evaluation occurs when behavior behavior raises questions of competence, and if there is refusal of treatment that would be clearly beneficial. An evaluator should be an expert in mental status and understand medical implications of care decisions. So you're always in this process of balancing autonomy versus harm. So here's Mr. M. He has squamous cell carcinoma of the skin. Obviously, this was initially curable with minor excision, but I think he had a pathological denial of deformity and consequences, and had a delusion about his condition, both the cause and also the potential outcome. So what happened when the city attorney arrived is Mr. M was in his hospital bed, and I met him at the bedside along with our chief resident. And the attorney said that he would like to take a look at Mr. M and speak to him. So he came in and had a conversation with Mr. M, and he had the bandage wrapped around his head. And the attorney said to me, "Please unwrap the bandage." And I said, "Okay." And I asked Mr. M's permission to do so. I unwrapped the Curl X and revealed the tumor. And I swear to God, this is true, that as soon as I did that, a fly landed in the center of the tumor. The city attorney turned white, walked out of the room, and immediately took over the consent process for the patient. Immediately. It didn't take him more than seconds to do so. And I thought it was stunning, the difference between my colleagues in psychiatry and the city attorney, who was actually an expert in competence. And it didn't take somebody outside the medical field long, and he did have experience with this, by the way, to immediately realize that this was not rational decision-making for this gentleman to walk around like this. Now, I have to tell you that our chief resident, who's a very good friend of mine, and I have a tremendous amount of respect for, he actually didn't agree with getting the city attorney involved. He thought that the patient did have capacity and competence to make decisions. So there was a little difference in opinion about what to do. So Mark Wax did a really nice paper in 2003 in Archives of Facial Plastic Surgery. And he had 43 patients that existed with this type of problem. Of the 43 patients, he was able to proceed with surgery and get negative margins on 28. 25 had no evidence of disease after the surgery, and 3 in that group had local recurrence. 15 of them had positive margins after surgery, where NED 3 and local regional recurrence occurred in 12 patients. And this was the extent of the surgery. Orbital contents being removed, maxilla being removed, mandible, oracle, craniofacial surgery, or extensive nasal surgery. And he used a wide variety of flaps, which I know we discussed yesterday with Dr. Garneau's lecture. So the outcomes for this type of advanced skin cancer was there was total flap loss in 3. Nobody died from the surgical intervention. There was partial flap loss in 2. 2 had intracranial complications. 5 had hematomas. And the overall flap success rate, of course, Mark Wax is always thinking about how did the flap do, right? But 93%, 58% were alive with no evidence of disease, and 42% had recurrence. But he was able to get conclude that negative margin status, if they were able to get negative margins on something like this, that the patient would in fact be able to survive. 90% survived if they had negative margins. So what happened with Mr. M? So we set up Mr. M for surgery again. This time there was a monitor placed in his room. We got the teams together, took the OR time. He was actually on board with proceeding, just like last time. And we had the external legal steward for him sign the consent form. About 11 o'clock at night, he got up and wanted to leave, and the monitor actually would not permit him to leave. So he was now in a forced situation where he was not permitted to leave the hospital. At 6:30 in the morning, he was brought down on a gurney. He was in the patient hold area. He was very calm and polite, as he always is, and he met the main oncologic surgeon who was going to do this surgery. It was not me, and came in and greeted him. And of course, this our surgeon on our faculty was quite familiar with him. And Mr. M said to him, "Are you going to operate on me even though I don't want to be operated upon?" And the doctor said, "Well, we had a legal determination of your competence, and we were going to proceed with removing this for you, and had a pretty extensive discussion about the benefits of having this out and talked about survival rate." And he said, "Is this Nazi Germany? Are you going to operate on me even though I don't want to be operated on?" And the surgeon looked at him and said, "No, Mr. M, we're not," and canceled the surgery. The DSM-5 does not have in its scope and scale the concept of body dysmorphic disorder combined with suicidal ideation. That category does not exist in the psychiatric realm. I think that that's what this patient had. He had body dysmorphic disorder about the damage that this huge tumor was doing, the problems that it was causing. But I also think he had suicidal ideation, that he was actually thinking about this being the cause of his demise. And this type of pathology is not easily recognized in our psychiatric realm. And yet, although rare, it's something that you will, I think, repetitively encounter. Now, I've had patients with advanced disease walk out of my office without seeking therapy. And I'm fine with that if that's what they want to do. And we'll take care of them, and we'll recommend hospice care for them. We'll go through that whole thing, and I'm fine with that type of thing. But the special problem that existed here was, one, the curability of this disease. And number two was the repetitive entry into the healthcare environment. It's kind of like the Lucy and the football cartoon, where you get everything teed up in a resource-constrained environment and the football gets removed. Anyway, there was definitely a gap in what the legal profession thought about the progress of this case and what the medical profession thought about the progress of this case. So what happened to Mr. M? I got one of my very, very good friends who's just a superb internist, and her name is Beth Harleman. And I asked Beth to become involved in his care and to basically supervise his hospice entry. And she did really a magnificent job doing that. And I think that he passed away from this disease about 9 months to a year later, is what I recall. but it was slowly progressive, started to take away function, started to cause pain, started to bleed, and it was not a pretty thing. But Beth did a great job where I couldn't do as good a job as she did. So I was really appreciative that she stepped in as a classic medical colleague to help Mr. M with his final year of existence. So I just want to point out that this is not that uncommon, actually, in a city hospital environment. So what did I learn from this? At the end of the day, I got sort of an exquisite education in the difference between capacity and competence. I had the realization that the medical and the legal professions had two different sort of approaches to this problem. And I also have a lot of respect for the struggles that people with this type of advanced disfiguring disease have. I think the very fact that you let something like this go to this extent means de novo that there is some psychopathology of a sort underlying it. And I believe there is a category of psychiatric disease that is actually not disseminated through our medical literature, which is body dysmorphic disorder with suicidal ideation. Thanks very much. I'd be happy to take some questions.
Thank you. I just wanted to also point out that for those of you who are on our Zoom, obviously you can't raise your hand, so just speak up and interrupt us. I mean, I see Edward, you're out there, and Zinnia, and so, and Dick. So please, if you're so inclined, you have a comment or a question, just speak up and we'll give you the floor. Thanks.
This is more, I guess, a comment than a question. I'm just curious from the members in the audience, if we could do it by a show of hands, how many people would have operated on this patient? And how many people would not have operated on this patient?
Yep, and I think that was also the sentiment at our institution. But here's the thing, that does not absolve you of getting the competence determination from the legal arm of our society. And by the way, I also mentioned that San Francisco is an extremely liberal environment. And I was actually quite surprised at how quickly the attorney came to the decision.
Hi, thank you very much. That was a really great anecdote and story. How much also do you think there's a component of like delusional fear of medical intervention? You even see that on a minor scale of people avoiding a vaccine because they just are terribly delusionally afraid of a shot or something like that. And, you know, I don't know how much medical care this gentleman has had over the course of his life, but there may have been, you know, before suicidal ideation, maybe components of that. Do you think?
Yes, I do think he was delusional about, actually, what he was delusional about was the causation. I think he didn't have a correct perspective about how quickly he would succumb to this. And I also think he was not actually, on the surface, he was manipulating the information he was receiving about risks and benefits, but I don't think he was stacking it up properly. I think he was overly and delusionally worried about the surgery itself, which I'm quite certain we could have gotten him through the surgery without having him succumb or pass away as a immediate result of the surgery. And he was emphasizing that.
Yeah, thank you.
Yeah. Great. Well, thank you very much.
Thank you, Dr. Mayor. That was excellent talk and perspective on these advanced cases that come in, and we see this all the time. And obviously, in head and neck clinic, this comes up pretty regularly. So it's great talk. So next, I'd like to introduce Dr. Darren Guffey. He's the Associate Program Director of Dermatology Residency here, and he is a Mohs surgeon who we work very closely with. He's agreed to talk to us about update on staging and gaining a different perspective on a particular staging system that we're not as familiar with. So we're excited to hear his talk, and thank you very much for joining us.
Good morning. I just wanted to first off thank you guys for inviting me to speak. I think that we share a lot of the same patients, and we have those same patients walk into our clinic, and it's sort of, where do you go next and what happened here. And but this morning, I'd like to talk with you guys about a little bit of overlap, a little bit of difference in more from a dermatology and Mohs surgeon perspective, and how we can better communicate using these different staging systems and how they've evolved over time. So I have no financial disclosures, no conflicts of interest, and I won't be discussing anything off-label. So from our perspective, if we get to the N and M part of the staging system, as dermatologists, we have failed in our job. So I'm going to focus on the T staging. And the two systems we focus on today are going to be the Brigham and Women's Hospital system and then the AJCC 8. And obviously with the AJCC, you have N and M categories in that. With the Brigham and Women's, which is developed by dermatologists, you do not. It focuses on T staging. I think to know where we're going, you kind of need to understand where we came from. So we'll talk a little bit about how the staging systems have evolved over time, and as well as their strengths and weaknesses. So, why are we up here talking about this? You guys deal with some really nasty tumors that we never see. And by and large, cutaneous squamous cell carcinoma, all comers, is not a life-threatening disease. Most of my patients, when they come in, I try and unpack that and say, you have a small, well-differentiated squamous cell carcinoma, you're not immunosuppressed, your risk of this metastasizing is very low. Or you have a patient who comes in, just like the gentleman we were talking about, Mr. M, I flip that on its head and I say, this is a very high-risk tumor. We need to do the full court press here. But there's a significant burden of disease in our country, and it's increasing rapidly. And we think of, squamous cell carcinoma of the skin not being that dangerous an entity, but you've got a burden of disease of 15,000 people dying from cutaneous squamous cell carcinoma in this country every year. And so if you stack up those statistics with something like melanoma that has this, big stigma attached to it, you got more people dying from non-melanoma skin cancer than melanoma skin cancer at this point. So why do we stage these tumors? Well, mainly to get an idea of which ones of these are going to be bad actors and identify situations where we might ought to scale up our intervention. And again, flip it on its head where we say, this is not something that's very aggressive to this is highly aggressive, we ought to do more. But also to help us better use our resources efficiently, because you can't image all these people, you can't get a sentinel node to all these people. And so which ones should we be spending those healthcare dollars on in this economically constrained environment? And so what makes a good staging system? So three principles here. You want each category to be distinct. So you want T2 to be worse than T1, you want T3 to be worse than T2. Within each stage, you want all those tumors within the stage to behave in a similar manner. And then as you climb the staging system, you want the tumors to do worse. So ideal staging system, everything in T1 behaves the same way. T2 behaves a little bit worse, but all T tumors are the same. And then as you climb the ladder, there's a big difference as you go up in T staging. So what staging systems do we currently have? And again, I'm going to focus on two of these, but there is the Union on International Control of Cancer, which is not one we commonly think about. The NCCN, which isn't as much a staging system as a guideline system that I think you guys are all aware of. A Tübingen system, which is out of a group in Germany, the AJCC 8, with a recent refinement we'll talk about briefly in the Brigham and Women's system. And so a little bit of history, and I had to do a deep dive on this because some of this predates my time in medicine. So the AJCC 6 was released in 2002. And I think it's kind of surprising, probably more from a dermatologist standpoint, maybe not for you guys, that they just sort of lumped everything that wasn't melanoma together in these staging systems and said, we'll stage them all the same way, even though we know that basal cell behaves wildly different than squamous cell. And there are all these rare tumors that you guys probably don't come up against that behave completely differently. But I said, nah, one staging system is probably fine for all those tumors that aren't melanoma. And they said, the bigger it is, the worse it's going to do. Obviously, if it gets down into the bone, that's a bad tumor. I think some of that's intuitive, but I don't think that it's very useful in saying which ones of these tumors are probably high risk or sheep or wolves in sheep clothing that we should be watching closer or doing more for. So fast forward to 2010, they released an update. They realized that maybe Merkel cell should be split out because that's a bad tumor too. So they split out Merkel cell carcinoma, but they still lumped everything together, including squamous cell carcinoma, basal cell carcinoma, and anything else you can think of. And this staging system, they excluded tumors on the eyelids and mucosal lip and the genitalia. Some of those are intuitive, some of them aren't. I think tumors on the eyelid and mucosal lip, a lot of them are actinically induced and probably should be staged together. Genitalia, probably more HPV related, so maybe that makes sense. And they started to recognize there are other high-risk features. And although you're still staging all these other skin cancers together, we're thinking now more about specifically cutaneous squamous cell carcinoma and looking for things like perineural invasion, depth of invasion, and specific locations. And so a little bit better, probably a little bit more granularity, but the bulk of poor outcomes are still happening all in one T stage, which is very large. So you have 87% of your poor outcomes in T2. However, a large proportion of those patients do very well. And so if you treated them all the same, you would be over-treating a large proportion of patients or under-treating them for that matter. And so to summarize the problem around 2012, one, there are no large registries for these tumors, not like melanoma, not like breast cancer and things like that. Cutaneous squamous cell carcinoma is really not being talked about or considered and registered. Again, we're lumping all these different tumors with different biologic behavior together and trying to stage them with the same staging system. And again, we get back to those basic principles. The AJCC7 lacked the distinctiveness between categories and the homogeneity within a category to really allow us to prognosticate these tumors. And then almost no tumors are staged T3 or T4. That's probably selection bias. You guys probably saw all those tumors, and we saw virtually none of them except when they walk in the clinic and we quickly pass them off, which is a good thing. But what is the utility of those categories if less than 1% of your tumors are staged that way? And so this German group that developed the Tübingen staging system sort of commented on that and said, both of the systems we have right now are imperfect. They don't tell us anything about the rate of metastasis or local recurrence of these tumors. And some of the criteria are somewhat arbitrary. And so they advocated for more research, including eyelid and lip locations together, eliminating everything but cutaneous squamous cell carcinoma from the staging system we're developing. And they also advocated for including immunosuppression, which continues to be a point of contention in the current staging systems. And so here's the seminal paper in our literature, and it's out of the Harvard group led by Chris Schultz. And essentially, they looked at this exact problem, and it was a retrospective study focusing mostly on high-risk squamous cell carcinoma or on high-risk squamous cell carcinoma. And what they really sought to do with this study is to take that T2 category and subdivide it and figure out, okay, which one of these, we know that there are bad tumors in here. We also know there are tumors that aren't going to really do much in here. Can we figure out which is what? And so that's the reason you have a T2A and a T2B in the Brigham and Women's staging system, because it's the old AJCC7 T2 split into two parts. And they did not limit their study to head and neck location. The AJCC staging system was developed for head and neck tumors. And so just some preliminary data you can see here, just to point out, they took these T2 tumors and split them into T2 and T2A and T2B. And you can see, based off the percentages here that you're going to have, there is a break point between local recurrence, nodal mets, and disease-specific death as you go from T2A to T2B. And so what is the staging system? Essentially, there are 4 high-risk features for Brigham Women's. And as you collect features, obviously your tumor gets upstaged. So the features they care about are perineural invasion of a nerve greater than 1 millimeter in diameter, invasion deeper than subcutaneous fat, poor differentiation, and we'll talk a lot about that in a minute, and diameter greater than 2 centimeters. So again, if you got no high-risk features, you're T1, 1 high-risk feature, 2A, and then you get to your break point. If you have 2 or more high-risk features in their system, you become a high-risk tumor at T2B. And so what did this achieve? Again, they took that AJCC T2 category, split it into, and eliminated the low-risk tumors, put them in T2A, and identified high-risk tumors and put them in T2B. And again, here's a breakdown on their study. You can see that there's a clear breakpoint there, and T2B tumors do worse. And then like any good study, they published a follow-up study and validating this and comparing their system to the AGCC8. And the take-home points here were that all the poor outcomes in AGCC happen essentially in T1 and T2, that T3 and T4 tumors are rare, but that's a very heterogeneous group. And then within their staging system, all the poor outcomes were really clustered in T2B or worse, and therefore identified a smaller subset of tumors that were better targeted for, more aggressive interventions. And data from that study, again, this is 10-year incidence here of local recurrence, nodal mets, and disease-specific death. And again, a ton of tumors here in T2, split up in T2A and T2B. And again, you're getting a smaller group of tumors here in the T2B, and they are doing worse as you look at these poor outcomes. So an update of the AGCC was released in 2017, and we're now in present day with these staging systems. And so they actually dropped a lot of the high-risk features that were included in AGCC7 and focused mostly on depth of invasion, size of the tumor, and whether or not there was perineural invasion. And so here there's a shift between the high-risk tumors occurring in T2 to now T3, because you can get to T3 one of three ways. You can be larger than 4 centimeters, you can have PNI, or deep invasion. And again, this sort of mimicked the work done by the Brigham and Women's Group to try and make this a little bit more comparable. And they dropped poor definition. And that's the big difference between these two staging systems now, is this histologic grading. And the reason they dropped that is that they said it's too subjective, and there is a lot of subjectivity in that. Dr. Russell and I look at these tumors under the microscope on a daily basis, and what's poorly differentiated for us, our dermatopathology colleagues may not agree. They say it's poorly differentiated where you saw it, but most of the tumor is well to moderately differentiated. And there's a disagreement on whether or not you should be grading a tumor off of its worst day, if you will, or 95% of its tumor bulk. And what I would say is that we see them do bad things at the base, and even if that's only 1% of the tumor, that's what we probably care about. We don't care about what it's doing on top. But this is a subjective category, and the AGCC decided that they were going to drop that. So there are lots of head-to-head comparisons, and I'll kind of breeze through these, essentially stacking these staging systems up and applying them to different patients. And we'll just kind of read through the conclusions and the number of patients from these papers. So 263 tumors. They behave similarly in immunosuppressed patients. This is out of JAMA Derm, 680 tumors. This is written by the folks who came up with the Brigham and Women, so there's a little bit of a slant here, but they found that they identified the high-risk tumors in a smaller cohort of patients, and therefore their system is better at figuring out where to use healthcare resources, was their argument. This is in the JAD, the Journal of American Academy of Dermatology, saying that there's a lot of overlap between these two staging systems, which is true, that they both identify high-risk tumors, but there's room for improvement. And then from one of your journals here, the Journal of Oral and Maxillofacial Surgery, they looked at 695 tumors. And essentially, they're saying there's a lot of overlap. Some tumors were upstaged, some were downstaged, and it didn't necessarily, some of the tumors that were downstaged did poorly, and some of the tumors that were upstaged, if you apply Brigham and Women's, did fine. So clearly, these systems are still imperfect. And we'll do a little bit of a deep dive on two of these papers. This is the one out of JAMA Dermatology by the Boston group, again, 680 tumors. And you can compare here the Brigham and Women's versus the AGCC, again, T2A and T2B versus T3. As we go across, you've got local recurrence, nodal mets, and disease-specific death, which is what we tend to focus on in these studies. And their argument here was that they identified, again, a subset of tumors, 8% of their tumors were high risk versus 18%, and that all of the poor outcomes clustered, or most of the poor outcomes clustered in this smaller 8% of tumors. And then just a side note from the article in Oral Maxillofacial Surgery, and this is sort of a to be determined component. They said, what, the metastatic rate of these high-risk squamous cell carcinomas exceeds that of melanoma, and yet we're doing sentinel lymph node biopsies for melanoma. Why are we not doing sentinel lymph node biopsies for high-risk cutaneous squamous cell carcinoma? And we don't really have the answer to that yet. Some people are doing them in certain cases. Certain institutions do them more than others. I would say it's not our standard practice here to do that. But maybe we ought to be, because these are high-risk tumors. And so where are we now? So we know these systems are imperfect. People are trying to make them better all the time, but without making them too overly onerous. And so this is a group out of Spain that was trying to improve the AGCC-8 staging system. And we won't get bogged down in the details, but essentially they were looking at those 3 high-risk features and saying, well, if you have 2 of them, can you kind of create a subclass of T3? And it does a little bit better, but it doesn't blow the Brigham and Women's out of the water. So I'd say currently these systems are very comparable, but what they're good at is saying this tumor is probably not going to do anything bad. So if you're T1 for Brigham and Women's or T1 or T2 in the AJCC, you can kind of reassure that patient that this tumor is unlikely to behave in a bad fashion. However, if you are staged in one of those high risk stages, the positive predictive value of both these systems is pretty darn crappy. So we still have a lot of uncertainty within this high risk category of which ones of these tumors ought we do more for? Where do we spend more time, money, and resources? And which one of these patients do we follow up more closely? And just to touch on the NCCN guidelines, they kind of threw everything at the board and saw it stuck and left everything out there and kind of left it up to us. They're guidelines. It's not a staging system. Pretty much anything that's ever been looked at is considered in their guidelines, and they essentially tell you which tumors are going to do really well, and you can probably loosen the leash on these tumors a little bit versus which ones you really ought to be doing more for. And so no high risk features versus high risk features that are included in staging system over here on very high risk. And then everything that we don't really know that's at some point has been discussed, like immunosuppression or location on the ear or lip. So things that we know as clinicians and from old data is probably important, but not important enough for a staging system, kind of get you somewhere in the middle. And you can do a deep dive and go through all your flow charts and figure out what we ought to be doing for these, but there's still some outlying questions. I think that we've identified a large subset of high-risk tumors, but I think we need to get a little bit better than that so we can figure out how to apply these workflows and these nomograms a little bit better. So to kind of summarize what's not considered in our current staging system, again, Brigham and Women's and AGCC-8. So if you have multiple small caliber nerve involvement, to me, that can be more frightening than one nerve that you can track very easily because these can be very diffuse small nerves. And it's like they're taking every side road to the main highway, even though they're not taking the main highway. Immunosuppression, I think all of us know, and it's intuitive that those patients tend to do worse, but that's not included as a high-risk feature. Again, they've excluded sites, ear, lip, and temple. And again, we can do a raise your hand type thing and see, whether or not people think those tumors do worse. I think we all think that they do, and there's good evidence that they do, but not included in the staging system. And then maybe a little bit esoteric for you guys, but there are all these different histologic subtypes that are not poorly differentiated, but dispersed growth pattern or bad growth pattern, if you will, that are not included in the current staging systems. So again, to summarize, these systems are really comparable, quite frankly, in how they prognosticate these tumors, but they're both imperfect. The Brigham and Women's staging system may have an edge in terms of distinctiveness, meaning that it identifies a smaller subset of high-risk tumors. It may identify less tumors where we can spend our money a little bit more efficiently. Both of them are pretty good at telling you which tumors are going to do well, but not very good at predicting which tumors won't do well. And the reason that we always talk about Brigham and Women's staging system is that it came out during a time when the AGCC was not that good. It was developed by dermatologists, and it really talks about T-staging, which is what we care about. But most of the rest of the healthcare system talks about NCCN and AGCC-8. So I think it's good to be well-versed in both languages. And again, there's a lot of overlap, but that's the reason it's preferred by dermatologists. And again, they both identify high-risk tumors, and those warrant close follow-up. So I'll close with this. What do we not know? Where are we headed next? So should we be doing sentinel lymph node biopsies in these patients? And then what do you do with that if it's positive? How much does postoperative radiation therapy help in the adjuvant setting, in the neoadjuvant setting? How much does it reduce poor outcomes? Should we be imaging these people more routinely? If you go talk to a bunch of dermatologists who are following a lot of skin cancer patients and ask them how often they're imaging their patients, they're probably going to look at you sideways. But it's much more familiar to you all, and there probably is a role for it. And then gene expression profiling, which is where I think that we're going to get a lot more data soon. And what we're starting to look at here is, can you do better with that positive predictive value? Can you then select those high-risk tumors, or at least that cohort, and then find out which ones are really going to do bad? And this is the new kid on the block. And I have no stock or any conflicts of interest with Castle Biosciences, but they have a melanoma Decision DX test, and now they have a cutaneous squamous cell carcinoma Decision DX test. And it can sometimes help you figure out what to do with that high-risk patient, whether or not you should image them more frequently, whether or not you should consider adjuvant radiation in a patient who really doesn't want to do it. It sort of sorts them into sort of low risk, high risk, and highest risk groups. And the rate of metastatic disease within 3 years in those groups is 9%, 40%, and 60%. So it helps you out. And it's an independent predictor of those outcomes, or that outcome above and beyond our current staging system. So it's the new kid on the block, data forthcoming on that. And then what role do the new checkpoint inhibitors have in the adjuvant setting? I think we all know if you've got widely metastatic disease, you should probably be taking one. But if you have a highly aggressive tumor with a 60% risk of metastatic disease with, clinically negative nodes and negative nodes on imaging, should you be putting that patient on immunotherapy? And here are my references, and I'll take any questions from you guys.
Hey, Darren, I thought that was great. Thank you so much.
Thanks for having me.
From our end, we look at things differently because they go to you and then and they come back and we're done, right? But I would imagine from your perspective, looking at these tumors under the microscope, when you talk about high risk, or what would make you nervous, it would primarily be, yeah, you cleared it, but you guys just don't feel that maybe that confident in yourselves. So if I think about what scenario would you say, well, I stopped because I didn't see any more tumor, but maybe there was a lot of inflammation that I left behind or so forth. I would imagine one would be, that's why it would make sense in an irradiated field or recurrence, in other words, where there's a lot of scar from a previous reconstruction, perhaps. But the other things don't entirely make sense to me. Location. I mean, take a tumor on the ear or the lip, but when you cut it out, are you not confident that you got it all?
So typically we are. I would say that they've taken this out, and that's the reason those locations are no longer in the staging system, is that I think those other high-risk features tend to cluster in those locations. So if you see a tumor on the temple, just like Mr. M, that grew rapidly. It was probably poorly differentiated and probably wrapped around the nerve and probably down to fascia at a minimum. So I think when they started shaking the box, I think those things said, yeah, they're relevant, but it's because they overlap and cluster with these other features. Because yeah, I mean, if it's a well-differentiated tumor on a temple that doesn't go deep, we know that we got it. And it's probably not doing anything worse. But again, I think that we've noticed over time, and the data would say over time, that those bad tumors tend to happen in those locations for whatever reason.
Yeah. And then was recurrence a high-risk feature? Well, did that
so
count?
they didn't find that. They didn't look at recurrent tumors in the current staging system. These were all primary tumors. And then if you go to the NCCN guidelines, obviously they definitely give the nod to recurrent tumors being more aggressive. But the current staging systems there's always a subclass for recurrence in AJCC, but the Brigham Women's was developed on primary high risk cutaneous squamous cell carcinoma. So I think we all know that it's a high risk feature. I can talk to about one patient and talk to both your questions or comments, because I was here last night at about 9:30 working on a tumor that an immunosuppressed patient on the chest that recurred in a scar. And I got clear margins, but this thing is tracking in 1 or 2 cells, right? So in some cases, you get this phenomenon called skip spread, where it starts along a nerve, and in your section, it's clear, but if you section beyond it, you might find more tumor. And so that's where we're saying we're clear, but with a caveat. These well-differentiated squamous cell carcinomas, basal cell carcinomas, things like that, most of them would say, we're clear, do what you got to do. But that guy sent additional permanent sections, which I don't typically do, is for them to do immunostains. And I'd really like to have him do radiation. He doesn't really want to do it. So he's a guy we're going to set up for the Decision DX. And if he's low risk, then I'll probably acquiesce. And if not, I'm going to push him to do it. If that makes sense.
This is Dr. Robbins. A couple of questions. One's very basic, I guess. How long has Mohs really been well accepted and in practice? 25 years? How long has it been?
Well, my more senior colleague can comment better on that, but it was developed in the 30s and sort of sort of relegated to the sidelines and sort of frowned upon for the first few decades of its existence. But as far as the gold standard, I mean, I think, that's a hard thing to put a number on. I mean, several decades, I would say.
Well,
Okay, Dr. Russell's going to cover that in a later lecture, so I got off the hook on that.
Okay, one more question. We had a Mohs surgeon, our first Mohs surgeon come to town. I practiced in Newport News, Virginia for a long, long time. But anyway, and I had a real debate with her about Mohs surgery for squamous cell carcinoma. In other words, obviously it's a great thing for basal cell. I had difficulty accepting Mohs surgery being really efficient in clearing a squamous cell. Now, what kind of margin do you shoot for? Any difference in what you're shooting for between basal cell and squamous cell?
So typically, if it's a well-differentiated squamous cell and a basal cell, we're looking at maybe a 2 millimeter initial margin. If you've got a nasty tumor, something that's poorly differentiated or large, we'll go ahead and open that up to about 5 millimeters off the bat. But I think that the caveat I would say is that Mohs surgery is only useful in a situation where your tumor is growing contiguously. So if you think this thing is breaking off and you've got in-transit or satellite metastasis, Mohs surgery has zero utility in that situation unless you're debulking the primary tumor. And I think there are better ways to debulk a primary tumor than with Mohs surgery. So I think for most squamous cell carcinoma, I think that the data in our experience would say that it's a very effective treatment. But again, there are certain tumors where we wave the white flag and we say, look, this thing's all over the place. It's got skip spread, single cell spread. This is better suited for a wide local excision.
Well, she proved that it was very effective, very efficient, and she kind of won me over, but it took a while.
I think we have one more. Oh, Dr. Jameson.
Yeah, so I just want to make a comment and something we need to be very careful about, that, our staging systems, particularly AJCC, is designed to be prognostic. And is not designed to be directly tied to treatment decision making. And if you had a representative of the AJCC board here, they would have stood up right off the bat and made that distinction. So, and that is why you see a fundamental difference between NCCN, which is a treatment model, and you don't see if it's T1 do this, if it's T2 do this, right? You see a very careful effort to pick those things that might direct our therapy. And so I think we have to be very careful that the staging is aimed at putting a prognostic predictor, right? Which is also why there are no predictive outcomes for recurrent tumors, but we would all consider that to be, in quotes, a high risk feature. I think the other piece here is that it is exactly what you brought up, Darren, is that when you're looking at a tumor and you have a bad feeling, that is exactly why when you care for these tumors, you have to work in a multidisciplinary team, because you got to have somebody to share that bad feeling with. And you got to have people who say, yeah, I agree, and we need to do something about that. And I think that's why we hugely benefit from tumor boards that are truly multidisciplinary. And for these types of tumors that are actually tumor boards that are focused on, advanced skin cancers. And I think then we really outperform, any staging system in terms of how we manage these patients. I also think you're absolutely right that where the money is going to be is in the genetics, right? Because that, we're still looking at second and third order downstream effects of the genetic character of the tumor. And that's what we need to know to make these predictions.
Correct. That tumor has some advantage in its genetics that it's allowing it to pick up these poor features, and you'd like to get further upstream than that. I agree with you 100%. All right, guys, thanks for having me. I appreciate it.
All right, our next speaker, I'd like to introduce Dr. Mark Russell. So all of us are very familiar with him. He's spoken at this symposium before and joins our tumor boards regularly, and we've worked very closely with him. He's the director of Mohs surgery, and he's going to be talking about Mohs surgery from his perspective and his experience. So thank you.
Well, thank you for the introduction, and Dr. Minogue, thank you for the invitation to speak with your group here today. I've always been honored to be asked to speak to this group. We've worked together over the years, and I have the utmost respect for this group from top to bottom. Also, I want to thank John, our AV master technician, who always seems to make things work over the years. All right, well, I have no conflicts of interest to disclose. I am a dermatologist who's trained in Mohs surgery. And I wanted to maybe just touch on how a Mohs surgeon gets to their point of training and how we overlap somewhat with our otolaryngology colleagues, although we come at it from a slightly different training course, and how we develop our perspectives. And each one of you will develop your perspective over your careers. And perspective is a particular attitude toward or way of regarding something, a point of view. It's evolutionary, should be evolutionary and change over time, depending on your exposures and experiences. And I think it's a function, first of all, of your mentors. You tend to practice much like the people that train you in your specialty or in your residency. Then you have ongoing educational opportunities like this one, books you read, CME experiences, and peer-to-peer interactions, discussions, sidebar conversations here and there. And also your personal experience, where you take your perspective to your patients, you interact with them, and then you get follow-up, and then you develop, based on that. So my goal here is to just describe some of the evolution influences of dermatologic surgery and Mohs surgery, and I'll talk a little bit about how Mohs surgery has come to be where it is, and then present several examples of Mohs defect reconstruction, and maybe a few that are not so commonplace, maybe a little bit different. Other things to think about. A lot of us will see a defect and we'll have plan A, but sometimes plan A doesn't always work because of different reasons. So maybe give you a plan B or C to think about. So briefly, history of Mohs surgery and dermatologic surgical reconstruction. 1936 is when Fred Mohs finished his 1 year of surgical internship and then did his technique. He didn't call it his technique, it was chemosurgery then. And there wasn't a lot of reconstruction done then because of the way he did his tissue extirpations with the fixed tissue technique. But he started a procedure that to this day ends up creating a lot of defects for us to reconstruct. About 1956, he published his first textbook. His first articles were in 1941, but then he published a textbook. It became more commonplace at that point, but it was still a very, sort of isolated technique. And in 1967, after he had trained a number of people, they had their first meeting of the American College of Chemosurgery, and that has occurred annually now and still occurs under a different name. In 1970, a dermatologist who had trained with Fred Mohs reported success with something they called the fresh tissue technique, meaning they could cut the tumors out, look at the frozen sections, declare the margins clear, and then do an immediate reconstruction. So then there was immediate interest among dermatologists to do those reconstructions after they had the defect. In 1970, the first trainee completed a fellowship, a formal fellowship. Again, other people had trained with Fred Mohs at variable times and without a lot of formality. In 1975, the Journal of Dermatologic Surgery was established. And in 1985, they formally sort of changed the name to Mohs Micrographic Surgery. And here we see a couple examples of some textbooks that were written regarding reconstruction by dermatologists. So I want to go over now some of the perspectives that I have. Many of you probably also have about reconstruction after Mohs surgery. We want to maintain function, optimize cosmesis. I think we all agree on that. Minimize complications. I look at, and I think most of us look at, defect characteristics. First of all, what's the location of this defect, the size, the shape, the depth. And then we want to look at those tumor characteristics that Dr. Guffey had talked a little bit about, and Dr. Park had mentioned. What's the chance of recurrence for this tumor? And that's something you get, I think, with experience and staging. And histologically, we look at how aggressive does that tumor look. Also, how is it different than what it came in as? If you do a superficial biopsy of a squamous cell carcinoma, you may get something that's not so aggressive, well differentiated, and it comes in, and then during extirpation, you start to see some high-risk features. You got to shift your mindset, because I think you got to be as aggressive as the cancer you're taking care of. Also, what's the need for adjuvant treatment like radiation that may slightly affect the way you might approach the defect reconstruction. What's the chance of new tumors? If this is a patient, like many of ours, they're in for more than just one. And so you don't want to necessarily use a big gun for small game, and you want to maybe save some of your, for example, interpolation flaps for a later date. And then what's the possibility of tumors nearby? You don't want to advance or rotate or interpolate high-risk tumor skin into a defect reconstruction. And the one that sort of scares me the most is the hinge flap on a full thickness nasal sidewall, where you turn that nasal skin down into the nasal vestibule and you no longer can survey it. So, and then also patient considerations. What are their expectations? Are they a high vanity quotient? They really want perfection, or do they want convenience? Just get it fixed reasonably well, let me out of here. What's their ability to undergo the procedure and their ability to care for the wound? You may not want to do a high maintenance repair for someone who can't take care of it well. And again, the considerations about their health. What comorbidities do they have? What's their cognitive ability? For example, it would not be the first time, I hope it's the last time, but that I have put a skin graft with a bolster on a patient who turned out to have some sundowning dementia and pulled that bolster off that night. Are they sort of recalcitrant smokers? That should impact the decision. And what medications are they on that may impact their ability to heal and their complication rate? So again, more things in the equation to consider. And then also some introspection for that surgeon. What's your ability? What's your experience? What's your comfort zone? And is it something you can take care of, or do you need to lean on your colleagues? Something to consider. So some general principles. I like to treat every patient, every defect individually. People sometimes ask, isn't it boring just doing Mohs surgery all the time? Cut it out, fix it. Well, not for me. I don't know exactly why, but I think it's because every patient, every tumor, every situation has a slightly different variation. Simple is usually better in my experience, although when I was a fellow, I wanted to do all the complicated stuff so I could try it. Pre-op evaluation, I think, is good to avoid intraoperative surprises. Informed consent is critical, in my opinion, and post-op instructions can help maintain your best work. If you don't train the patient well how to take care of it, you may have decreased outcomes. So specific considerations: what are the skin reservoirs? If you're going to move skin in to repair a defect, where can you get it? This particular patient has some lax skin that's very available. Try to keep the repairs on cosmetic units or the suture lines at the cosmetic unit boundaries. Work within the relaxed skin tension lines, or make your lines parallel whenever possible. And be aware of the free margins. Try not to pull down on those, like the eyelid, the nasal rim, the lip, and the helical rim. And then also, what skin characteristics do you have in that area? Elasticity, how much mobility do you have? What's the vascularity, both for appearance and also for maintaining your flap? The more vascular, the better off it tends to do. And then what's the texture, thickness, the hair bearing quality, and the color of the skin, trying to match those up as best you can. So I have a ladder that I've used that I think about. It's not inviolable, and you can do different things with this, but when I first started training, I wanted something to go by. And so the mnemonic here is Spartig. It's second intent, linear closure, the various flaps, the various grafts, and then combinations of all of those. Something to start with. So let's start with second intent healing. Fred Mohs did a lot of this in the beginning because he had tissue slough that occurred after his extirpation, so he couldn't do immediate reconstruction. Let just about everything heal secondarily. We got a lot of information about what does well, what does not. It's best for concave areas, because when you heal something secondarily, it contracts, and there's a bit of depression that goes along with it. So when you put this into a concave area, it's a little less conspicuous. The wound should have a vascular base. So over bare cartilage and cartilage is over bare bone and cartilage is hard to let granulate, but can be done. You want to allow for those forces of contraction, because when it contracts, it may pull down, for example, on those free margins. And you can influence a wound by using guiding suture. And I'll show an example of that. So the darker pink areas are good ones for second intent healing. The lighter pink are fair convex areas, like the bulb of the nose or the rounded area of the cheek. Not so good. It can heal. Theoretically, it can heal. It doesn't always look so good. This is an simple example of an ideal wound. It's a very superficial wound in a concavity in a thicker skinned area. And over time, with just some simple wound care, cleaning it, a little Vaseline, protecting it, not using anything cytotoxic like hydrogen peroxide or alcohol. It heals in very well. Another example of a patient didn't want anything more. Another one of these, convenience is more important than cosmesis. And certainly I didn't think function was compromised, so we just let that one heal in by itself. It did reasonably well. And this is an example of a patient who has had multiple lesions on the nose, like many of our patients do. And you see he had a skin graft and how that was a little bit paler, not as vascular as the surrounding skin. Had a defect here right on the alar rim, and so it's going to be susceptible to contractile forces and rim contracture. But I think we talked about this last month, Dr. Park, about this guiding suture method of impacting the tension vector so that you push down a little bit on that alar rim so that when it contracts, there's a little extra skin there to absorb that contracture. Works okay in profile view, but we all know that the proof is in the inferior view of these things. So one of my cases, this is a high risk location to allow heal secondarily because it's right in that anterior aspect of the alar groove. It's thin, it doesn't have a lot of cartilage underneath of it, but we did the guiding suture and looks okay in profile, but underneath there's just a little bit of collapse there. So you just have to be careful with that. I want to throw in this article that talks about just using a batten cartilage graft in the base of this and allowing it to heal secondarily, not doing any kind of a repair over top of it. And you may say, well, why not do a repair over top of it when you put the cartilage in? And you can do it, but there may be, again, this may be plan B or C, and maybe the patient doesn't have a mediolabial flap or mediolabial or a forehead flap option. So it's a very conservative way to allow this to heal in, and over time, it heals in fairly well in profile, but also maintains the curvature of that alar rim. So maybe another option to think about. And this is a patient who said, I've had enough. I think this is a forehead. I know this is a forehead flap scar here in the forehead, and he had another one over here, fairly shallow wound. And the patient said, you know what, I just let it heal. And it heals very well. And there's even some linearization that occurs there. Larger defect, we partially closed it and allowed the middle of it to heal in secondarily. So this is at the end of April. And just to show you a timeline with letting something like this heal, about a month later, there's a nice granulation bed with conservative treatment. Another month later, it's contracting, it's getting smaller and still continuing to heal. It's a lot of work and it's a lot of time, but it is an option in certain situations with motivated, capable patients. I wanted to introduce or at least reinforce this concept of displaced triangles or cones for reconstruction. I'll show a few examples of how we use that, but I think we all know how to do an ellipse. We just add cones to this circular defect, close it up, you get a nice line. But for example, if you didn't have the option of continuing this cone in this direction, you can displace it and still get a reasonable advancement flap type outcome. So this is an example of where if you wanted to close this horizontally, you could take your anterior cone, no problem, but in posteriorly, you don't have that option. You got an ear there. So you just take it down another floor and then you put that cone under the ear and you get a reasonable advancement because the jowl is a nice reservoir for tissue. You can advance that up, you can close that up and have a reasonable functional cosmetic outcome. And just to look at this displaced cone concept a little bit, here are two defects, two primary defects. And I know it's sort of funny to see that little tissue paddle that we left in the middle, but when we get negative margins, we stop. So we stop. And we just displaced that cone a little bit, closed it up, had a reasonable outcome. So I think I talked about this flap some years back about the dorsal nasal advancement flap or east-west flap. I've wanted to love the bilobed flap since I was in training because it's the gold standard, the workhorse for the lower third of the nose. But I always had a little bit of problem with the curvilinear lines down there and some of the pin cushioning. And I use it when the defect really calls for it. But this east-west flap has sort of replaced, in many cases, the bilobed flap for me. It has linear lines and it helps displace any kind of tension evenly on the lower third of the nose. It's not for every defect, but it can be for some. This is an example of a small defect. And small defects have a lot of options, right? I mean, there's a lot of different things you can do, and you're probably going to choose based on those influences or those perspectives that you gain over time. But went ahead and just closed him, took the superior cone superiorly, and then we displaced that inferior cone equilaterally into the nasal tip and onto the columella so that we had equal pull on both sides. And I do use this a fair amount. Another example of a patient who'd had a skin graft on the tip of the nose, and you can see there a little bit of texture mismatch, color mismatch. And then he was unfortunately or fortunately had another skin cancer just superior and lateral to that. And so in designing the repair, he didn't like the graft. So we put that into the equation, and then we came up with a east-west flap that incorporated that graft, took it out, and at a reasonable cosmetic functional outcome at the end. And so that's the east-west flap. Many times our patients have more than one lesion at a time, and we have the opportunity to do combination closures where we incorporate both defects into one closure. So this is an example of a patient had two fairly large but primary and distinct defects. And because of our conversation, she did not want anything elaborate, did not want to be sent off to another surgeon, did not want grafts, so wanted something as simple as possible. So we added to the east-west flap, and we made it an east-west-east flap. You can see we displaced the cone superiorly and then again inferiorly into the columellar area. Close that up. It was tight for sure. And here we see preoperatively the inferior view and then postoperatively. And then she was relatively happy with that outcome with the way we approached it. And so again, another way to displace the cones, you like to be able to just do a simple closure, a simple linear closure, but you've got that free margin of the brow, and then you've got the convexity of the eyebrow as it goes onto the eyelid. So you displace that inferior cone to a more advantageous area, and there's our design. And then you advance the tissue in laterally and close it up and have a good cosmetic outcome. We don't displace her brow. Another example of this is a crescenteric inferior cone here. We see defect on the inferior nasal sidewall. You don't want to take that inferior cone down onto the ala if you can avoid it. Just would narrow that ala and maybe cause a little displacement into the vestibule. So you take it out onto the cheek, advance the cheek in, remove your cone. The key to these kind of cheek advancement flaps, in my opinion, is the tacking suture to bring that flap in and down and recreate that nasofacial sulcus. Another example, same thing, just a slight variation on the perialar crescentic. And another version where we take our cone, we displace that inferior cone. That's sort of the theme of this, into an area that's more advantageous. So here's a relatively small defect and a relatively high maintenance type of, not unreasonable, but she really wanted no scar. She has very few lines to work with. So we went ahead and used an island pedicle flap here, a common repair to use in this area, not the only repair, but one we did use, and sort of created or recreated a mediolabial sulcus here for her, and trying not to put any lines on a relatively lineless face. I wanted to bring this up. This is a variation of an island pedicle flap, but it's also got a fairly cool name. So wanted to, and then it also addresses a very unique area. This is not for every area, but because of the multiple cosmetic units involved here and the complex three-dimensional topography, this is a one-stage repair, relatively simple repair that you might consider. May not be your first or second line, but maybe something to think about. And you design this island pedicle to mobilize from the inferior aspect up medially and superiorly. But the concept here is that this shark has a mouth. And when you close it, the way to close it is to actually close the mouth of this and create an inverted scar line. But that inverted scar line will recreate the alar groove. And so here we see it removed and the suture being put in to close the mouth of that shark. That mouth is closed, but here you see a depression that it will eventually recreate that alar groove. Now they do tend to pin cushion for a while, like some island pedicles do, but over time they tend to flatten out. There are things you can do, but a relatively simple one-stage flap for a complex defect. And this is the outcome. But it's a very unique defect, and you have to wait a long time sometimes before you see the right defect to use it in. Rotation flaps are just a variation sometimes of this displaced cone concept that we talk about. So here we see a defect, and then we have a sort of an arc that we rotate this flap on. And the opportunity exists to displace that cone. You don't always have to displace a cone. So here's an example of a defect, and it's reconstruction drawn out. And you can put this cone way over here or anywhere along that arc if you want. As long as you take out the redundant skin on the outside of that arc, you can often get a very reasonable, cosmetic outcome. I did not have to use a cone here. And then here we see another upper lip defect. And before we'd use the island pedicle flap, but there are other options. And say you didn't want to or couldn't use the island pedicle, a little rotation can be designed here and bring skin in laterally and not displace the upper lip. And this is what it looked like. Did not have to use a cone here. I really don't like to use a cone here because it